Hello, this is Elizabeth Ikeh, HSC 250, reading case study 13-1, titled Total Abdominal Hysterectomy and Bilateral Salpingo-Oophorectomy. MT, a 60-year-old gravida para 2, has spent 3 months under the care of her gynecologist for treatment of postmenopausal bleeding and cervical dysplasia. She had had several vaginal examinations with pap smears, a uterine ultrasound, colposcopy with endocervical biopsies, and a dilation and curettage with cone biopsy. She wanted to take hormone therapy, but her doctor thought she was too much at risk with the abnormal cells on her cervix and the excessive bleeding. She had a total abdominal hysterectomy and bilateral salpingo-oophorectomy under general anesthesia with no complications and an uneventful recovery. Her uterus had been prolapsed on abdominal examination, but there was no sign of malignancy or pelvic inflammatory disease. The pathology report revealed several leiomyomas of the uterus and stenosis of the right oviduct. She was discharged on the second postoperative day with few activity restrictions. Case study 13-2, in vitro fertilization, also known as IVF. CA had worked as a technologist in the IVF lab at University Medical Center for 4 years. Her department was the Advanced Reproductive Technology program. Although her work was primarily in the laboratory, she followed up each patient through all 5 phases of the IVF and embryo transfer treatment cycle: follicular development, aspiration of the pre-ovulatory follicles, sperm preparation, IVF, and embryo transfer. Her department does both GIFT, acronym for gamete intrafallopian transfer, and ZIFT, acronym for zygote intrafallopian transfer. While the female patient is in surgery having an ultrasound-guided transvaginal oocytes retrieval, CA examines the recently donated sperm for motility and quantity. She prepares to inoculate the sample into the cytoplasm of the ova as soon as she receives the cells from the operating room. After inoculation, she places the sterile petri dish with the fertilized oocytes into an incubator until they are ready to be introduced into the female patient. Case study 13-3, titled Cesarean Section Birth. AY, a gravida 2 para 1 at 39 weeks gestation, had been in active labor for several hours, fully effaced and dilated, yet unable to progress. She had had an uneventful pregnancy with good health, moderate weight gain, good fetal heart sounds, and no signs or symptoms of pregnancy-induced hypertension. X-ray pelvimetry revealed cephalopelvic disproportion with the fetus in right occiput posterior position. Changes in fetal heart rate indicated fetal distress. AY was transported to the OR for emergency C-section under spinal anesthesia. After being placed in the supine position, AY had a urethra catheter inserted and her abdomen was prepped with antimicrobial solution. After dripping, a transverse suprapubic incision was made. Dissection was continued through the muscle layers to the uterus with care not to nick the bladder. The uterus was incised through the lower segment 2 centimeters from the bladder. The fetal head was gently elevated through the incision while the assistant put gentle pressure on the fundus. The baby's mouth and nose were suctioned with a bulb syringe, and the umbilical cord was clamped and cut. The baby was handed off to an attending pediatrician and OB nurse and placed in a radiant neonate warmer bed. The APGAR score was 9 out of 9. The placenta was gently delivered from the uterus, and the scrub nurse checked for 3 vessels and filled 2 sterile test tubes with cord blood for lab analysis. AY was given an injection of Pitocin to stimulate uterine contraction. The uterus and abdomen were closed, and AY was transported to the PACU, also known as Post-Anesthesia Care Unit. Questions. Number 1. MT is a gravida 2 par 2. This means that she's had 2 pregnancies and 2 births. Number 2. An endocervical biopsy is a tissue sample from the lining of the cervix. Number 3. Curettage is scraping. Number 4. A colposcopy is an endoscopic examination of the vagina. Number 5. Another name for leiomyoma is uterine fibroid. Number 6. Pregnancy-induced hypertension is also called preeclampsia. Number 7. The occiput of the fetus is the back of the head. Number 8. Pitocin is the trade name for oxytocin. Write a term from the case study with each of the following meaning. Number 9. Displaced is prolapsed. Number 10. Cell produced by fertilization is zygote. Number 11. Measurement of the pelvis is pelvimetry. Number 12. Upper rounded portion of the uterus is the fundus. Number 13. A method for rating a newborn's physical condition is APGAR. Number 14. After birth is placenta. Define each of the following abbreviations. Number 15. D and C is dilation and curettage. Number 16. BSO is bilateral salpingo-oophorectomy. Number 17. PID is pelvic inflammatory disease. Number 18. HRT is hormone replacement therapy. Number 19. IVF is in vitro fertilization. Number 20. CPD is cephalopelvic disproportion. Number 21. OB is obstetrics. Number 22. GYN is gynecologist. Number 23. GU is genitourinary. Thank you.